A very good afternoon to everyone. This is Dr. Arun Kumar. I'm faculty of pathology. So, first of all, I would like to thank each and every single person who have actually seen the video and responded to me in the comments and personally. It makes a huge deal to me. Thank you all. I've got some suggestions as well, and I'm going to follow them individually, and I'm going to execute it in my upcoming videos as well. So without wasting much of our time, as we have already discussed thyroid functional disorders overview in the last video, so we are going to continue that, and we are going to see what we can discuss in this lecture. So in that, what is we are going to discuss today is that we remember that we have discussed hypo and hyperthyroidism, right? So in this we have primary and secondary. Okay, pertaining to thyroid gland hormonal disorders, we are going to only discuss primary hypo and primary hyper. Okay, what should we do about secondary disorders? Because the secondary disorders are associated with hypothalamus and your pituitary, we are going to discuss them in detail when we are discussing about pituitary lectures. Okay, so coming to the primary hypothyroidism, we need to know there are multiple diseases, but one of the most important condition which causes primary hypothyroidism is your Hashimoto's thyroiditis. Okay, so Hashimoto's thyroiditis is very important, not just for exam but even for your clinical practice as well. So in primary hyperthyroidism, we are going to discuss something called as Graves' disease. Okay, apart from that, we are also going to discuss toxic goiter. Okay, it's not just that only these diseases are there coming when we are discussing primary hypo and primary hyperthyroidism, but these are the important things which one should never forget. Okay, so without wasting much of time, we will discuss primary hyperthyroidism, and the first disease which we are going to discuss, it is a Graves' disease. So as most of you might be knowing what is a Graves' disease, I am going to consolidate your knowledge about that. So Graves' disease, it is an autoimmune condition. Okay, so what do you mean by autoimmune condition? Your immune system is providing or producing something which is causing this disease. So this autoimmune condition, which is usually seen in females, okay, this autoimmune condition is producing something called as thyroid stimulating immunoglobulin. Okay, we call it as a TSIG. So what does this thyroid stimulating immunoglobulin do? So this thyroid stimulating immunoglobulin will go and it will stimulate the TSH receptors present on the thyroid gland. Okay, apart from that, it will also, because it is going to stimulate your T3 TSH receptors, it will increase your T3 and T4 levels. Okay, so this is what the normal overview of a Graves' disease looks like. Okay, when we are going to, now we will discuss something in detail. So how it is associated? So it has an HLE association of DR3 and DR8. Okay, so it has an HLE association of DR3 and, sorry, it's not DR3, it's B8. Okay, so it has an HLE association of DR3 and B8, and usually it is seen in a females but of childbearing age. Okay, so now coming to the clinical features of Graves' disease, it is important to know how does the manifestations happen. Okay, we all know that this thyroid stimulating immunoglobulin is being produced by the body. What does this do is that it will go and will stimulate the receptors present on the fibroblast. Okay, specifically it will stimulate the receptors present near the orbit and the tibia. Now what does it happen? Now what does it lead to? Because the receptors are being stimulated on the fibroblast, this fibroblast will secrete some substances, which what do you call, those substances are nothing but your glycosaminoglycans. Because the fibroblasts are producing more and more amount of glycosaminoglycans, these glycosaminoglycans will produce or will get accumulated near the tissues. Okay, see, these receptors which are being stimulated on the fibroblasts, these are present over entire body. Okay, but what interests us more is that the fibroblasts which are being stimulated near the orbit and near the tibia. Okay, because these glycosaminoglycans are going to get accumulated near the tissue, if it is going to happen in the eye, we are going to get something called as a exophthalmos. Okay, so what do you mean by exophthalmos? It is nothing but protrusion of eye. Exo means outside, so protrusion of eye outside. Okay, so what do you mean by outside? Does it mean it is coming or popping out of your eyeball? No. See, usually what happens is that your eyeball is supposed to be at a level exactly near your line of closure. So remember, let's say this is the palpable fissure. You can see that this is the line of closure. Okay, which means your eyeball is supposed to be beneath this line. So this is what is seen usually in every normal individual. But if you can see here, you can see this eyeball is protruded outside this line, and you can see it is even coming outside the eyelid as well. Okay, so this is what is called it as an exophthalmos. And why it is occurring? It is occurring because the glycosaminoglycans are being accumulated beneath the orbit, which is because of stimulation of your orbital fibroblasts. Okay, this is first thing. Second thing, we also have something called as a pretibial mixed edema. What do you mean by pretibial mixed edema? Simple. The fibroblasts which are present in the tibia, they are producing more and more amount of glycosaminoglycans, and that is being accumulated in the subcutaneous tissue and the connective tissue of the tibia. So that's what you call, or that's what will lead to something called as pretibial mixed edema. Okay, now when we look at the gross and microscopic findings of these Graves' disease, because it is stimulating continuously, the gland is getting stimulated continuously, you have enlarged thyroid gland. Okay, but when you look at microscopy, so coming to the microscopy of thyroid gland in Graves' disease, because your thyroid follicular cells are excessively stimulated by this thyroid stimulating immunoglobulin, these thyroid follicular cells will produce huge amounts of T3 T4 into your colloid. Okay, so because of this huge amounts of T3T4 being secreted into colloid, the colloid gets pushed away in such a way that as if you are scooping it with some spoon. Okay, so if you can see here, this is the colloidal lumen, but you can see this empty spaces here which is adjacent to the thyroid follicle. So here also you can notice here. Okay, so this characteristic appearance here you can see even more clear. Okay, this white spaces just adjacent to the thyroid follicular cells. So this is what you call it as a scalloping of colloid. Okay, very important microscopic finding which you see in case of Graves' disease. Okay, now the second disorder which we are going to discuss about primary hyperthyroidism is the thyroid storm. So what do you mean by thyroid storm is that usually it occurs whenever there is an excessive stress. Okay, so what do you mean by excessive stress? Let's say the patient is undergoing surgery. Okay, or if the patient is giving childbirth, or let's say the patient has underwent a road traffic accident. So what happens is that in this condition you have a stimulation of your sympathetic nervous system, and because of this you have elevated levels of catecholamines, right? So because your sympathetic nervous system is being activated, you have high levels of catecholamines. Because you are having high levels of catecholamines, if you remember your physiology, your catecholamines act as a synergistic effect with thyroid hormones. Okay, synergistic to your T3 and T4. This is what will lead to hyperthyroidism. Okay, very important. And people say if you are suspecting thyroid storm to occur in a patient, usually they are given with propylthiouracil or beta blockers before doing any intervention. Okay, so it's not given for everyone, but if they are suspecting there could be an impending thyroid storm, then definitely they are given with propylthiouracil, which is anti-thyroid medication, and beta blockers as well to prevent cardiac comorbidities. Okay, to address the cardiac comorbidities. So this is another important primary hyperthyroidism which we need to discuss. Okay, so after discussing about hyperthyroidism, we are going to discuss one important entity called as multinodular goiter. What do you mean by multinodular goiter? You have a increase in thyroid gland size, but nodular way. Okay, so you have multiple nodules. You can see in the image on the right side where you have, this is a total thyroidectomy specimen where you have a nodular swelling which are multiple in nature. You have multiple nodules which is enlarged, which is causing the enlargement of thyroid gland. But why it is actually causing? See, remember this thyroid gland which is increased in size but in a nodular way, it's actually due to relative iodine deficiency. Okay, so what do you mean by relative iodine deficiency? Because of certain dietary preferences. Okay, especially people who are consuming lot of goitrogens. Okay, what are your goitrogens? Your cabbage, cauliflower. Okay, so all those are goitrogens. So what happens is that when people are consuming a lot of goitrogens, especially in their diet, these goitrogens are not going to affect the normal production of your T3 T4, but once the T3 T4 are being secreted into your circulation, it will remain or render ineffective. Okay, some receptor mediated interaction is happening there. That is what is causing the relative iodine deficiency. Okay, now remember, this multinodular goiter patients are almost always euthyroid, which means you are having normal T3 and T4. Okay, even though grossly you are having a thyroid glandular abnormalities, functionally when you are doing assays of T3 and T4, you usually they are almost always euthyroid. Okay, now if you look at microscopy, you can clearly see that these thyroid glandular follicles, I mean when you look at the thyroid gland, these thyroid gland will have follicles of various sizes. See here, this is one size, okay, very large, and you have another follicle. So you have thyroid follicles of varying sizes. Okay, so this is one important microscopic finding which you will see in multinodular goiter. Now next we will discuss something which is next we are going to discuss about primary hypothyroidism. In that, the first thing which we are going to discuss is Hashimoto's thyroiditis. Remember, Hashimoto's thyroiditis is also an autoimmune condition, and in this condition you have a destruction of thyroid gland. Okay, so you have a destruction of thyroid gland. So how does it occur? Actually, it is associated with HLA-DR5. Okay, it is seen in females mostly because it's an autoimmune. Remember, any autoimmune condition, it's more common in females. Okay, and it is seen in age group of 40 years. Okay, females at the range of 40 to 50, which is actually a middle-aged female. Okay, and remember, Hashimoto's thyroiditis is the most common cause of hypothyroidism in iodine sufficient areas. Okay, so in iodine sufficient areas, which means you are developed countries. Okay, so sometimes they can ask as developed countries, sometimes the question can be an iodine sufficient area. So in that cases, autoimmune destruction, which is your Hashimoto's thyroiditis, is the most common cause of primary hypothyroidism. Now what happens in this disease? So remember, in Hashimoto's thyroiditis, you have autoantibodies directed against thyroid peroxidase, you have autoantibodies uh, directed against thyroglobulin. Okay, and you have autoantibodies directed against TSH receptors. So once these autoantibodies are there, these autoantibodies will cause destruction of thyroid follicles. Okay, so once this destruction of thyroid follicles are happening, so for example, you remember, how does this manifest clinically? Initially, let's say I am having 5 follicles. Okay, let's say for example, and in these 5 follicles I am having 5 hormones. Okay, so let's say 1 2 3 4 5. Now let's say these follicles are being destroyed. So the moment the follicles are being destroyed, these hormones which are present within these thyroid follicles will enter your circulation. So now how many thyroid hormones? This is just an arbitrary number for you to understand. Okay, so you have a thyroid hormone level of 5, let's say. Now what happens, because of there is heavy amount of thyroid hormones in the circulation, initially these people will have hyperthyroidism. Okay, now once the hormone is in the circulation, it has its half-life, so the hormones will slowly get metabolized. Once it is getting metabolized, the 5 may become 4, 4 may become 3, 3 may become 2, right? So it will become euthyroid as the patient progresses in the disease. And once there are no hormones in the body, where let's say all your follicles are being destroyed in the advanced stages, so that's when the condition will become hypothyroid. Okay, so this is very important. Why? Because even though we are discussing Hashimoto's thyroiditis under hypothyroidism, initially the presentation will be hyperthyroidism because of the acute destruction of your follicles. Okay, so as the glandular destruction progresses, as there are no further follicles left for the hormone to be produced, that's when the patient will land in hypothyroidism. So let's say if you make a graph, okay, over the time, let's say these are T3 T4 and this is your time. Okay, let's say this is your euthyroid level. Okay, this is your euthyroid level. Initially the patient will have hyperthyroidism, then they will come back to euthyroidism, and then it will be a continuous hypothyroidism. So this is how a graph will look like in a Hashimoto's thyroiditis. Okay, now how does it will look in a microscopy? Remember, microscopically, because your glands are being destroyed continuously, those destruction will be trying to be prevented by your immune system. Okay, so that's when your gland will be replaced by germinal centers or follicles. So if you see in this image, see, these are your normal thyroid follicles, right, which you can see with colloid in the center. But if you see here, this is your germinal center, which is usually seen in a lymph node. Okay, so this is what you see in microscopy. You have a lymphoid follicular aggregates. Okay, you have lymphoid follicular aggregates, okay, within the normal thyroid gland. Another important characteristic finding which is frequently tested in your exam is something called as a Hertel cell change. Okay, so what do you mean by Hertel cell change? Remember, because your gland is being destroyed continuously, these follicular cells will undergo something called as a metaplasia. Okay, because of the continuous stress which is happening or occurring on the gland, the thyroid follicular cells will undergo some sort of a metaplasia. This is called as an oncocytic metaplasia. So this oncocytic metaplasia which is seen in Hashimoto's thyroiditis, those cells you specifically name as Hertel cells. Okay, very important. Remember, Hertel cells are also called as Ashkenazi cells. Okay, remember, it is also called as Ashkenazi cells. Very important. So whatever you are seeing all here, it is nothing but Hertel cells. It's nothing but an oncocytic metaplasia. Now remember, those patients with Hashimoto's thyroiditis have an increased risk of developing extranodal B cell lymphoma. Okay, it is post-germinal or extranodal B cell lymphoma. Okay, so that is very important to remember about Hashimoto's thyroiditis. Now we are going to discuss another entity about hypothyroidism, which is your subacute thyroiditis, and simultaneously we'll discuss something called as Riedl's fibrosing thyroiditis. Okay, why? Because this is actually very confusing for everyone. Okay, subacute thyroiditis, it's also called as de Quervain's thyroiditis. Okay, so de Quervain's thyroiditis, remember, subacute, it means that it follows a viral infection. Okay, usually an upper respiratory tract infection. This is first important thing to remember. And remember, here the thyroid is tender, okay, which is painful thyroid. Next, patient will become normal once the illness is subsided. Okay, so it subsides if infection is cured. So these are the three important things you need to remember about subacute de Quervain's thyroiditis. Now when you look at the microscopy, this infection in microscopy will cause granuloma. Okay, the same granuloma which you are going to see in a TB, the same kind of granuloma will occur, but it will occur inside the thyroid. Okay, so this is what you need to remember about subacute thyroiditis. Now, what do you need to know about Riedl's fibrosing thyroid? Actually, I have included the word fibrosing in the title of the disease itself because it's easy to remember. See, remember, this is fibrosing. Fibrosis in general pathology, usually, it's a chronic condition. So in subacute is a subacute condition, but Riedl's thyroiditis is a chronic condition. Okay, and you have, as the name implies, you have a fibrosis of thyroid gland. Okay, you have fibrosis of thyroid gland, and remember, this fibrosis will make hard thyroid. Okay, so they say it is hard as coconut. So this is what will actually differentiate between radial fibrosing thyroiditis and subacute thyroiditis. Another important point I almost forgot, this is a painless. Okay, this is a painless swelling, but in case of subacute, it is a painful swelling. Okay, so we'll look at some images about subacute thyroiditis. See, if you see here, you can see this is a thyroid follicle. Okay, this is a thyroid follicle, this is also a thyroid follicle. Okay, this is thyroid follicle, this is thyroid follicle, this is thyroid follicle, but surrounding to this, whatever you are seeing, these are your granulomatous reaction. Okay, so this is another, this large image, this is also a granuloma. So you have a granulomatous infiltration of the thyroid gland. Okay, so these are the important hyper and hypothyroid conditions which one should remember. Now to consolidate our knowledge, we'll just deal or do some MCQs. Okay, so let's say here they are saying a 32-year-old female who is having anxiety, weight loss and excessive sweating for 4 months. She also complains of progressive eye bulging. Examination, you have an elevated T3 T4 and suppressed TSH, so which is a primary hyperthyroidism, which is Graves. Biopsy of the retroorbital tissue is performed. Which of the following is the most characteristic pathological finding? We have already discussed, it is because of accumulation of glycosaminoglycans. Okay, this is the answer, because the fibroblasts are being synthesized, being stimulated, which produces a lot of amount of glycosaminoglycans. Now, where do you see neutrophilic infiltration in abscess formation? This is nothing but an suppurative infection or any acute infection. Okay, so this doesn't suit the hyperthyroidism, which is Graves. Fibrosis with deposition of collagen bundles, we just discussed, it is radial fibrosing thyroiditis. Caseating granulomas with central necrosis, it is subacute. Okay, so the only option which is matching with the primary hyperthyroidism is your C. Okay, next question. A 40-year-old female presents with fatigue, weight gain and cold intolerance. Okay, see, 40 female, fatigue, weight gain, cold intolerance, features of reduced T3 T4, which is hypothyroidism. Reveals painless diffusely enlarged thyroid. Laboratory levels show elevated TSH and positive anti-TPO antibodies. Which of the following is the most characteristic histopathological finding? We just discussed, it is going to be a Hurtl cells. Okay, you have a lymphoid infiltration with germinal centers and Hurtl cells. Where do you see scalloping? This is what you see in Graves disease. Okay, scalloping is Graves disease. Granulomatous inflammation, again as I discussed, subacute. Fibrosis, radials. Okay, next question. We have a 35-year-old female with painful swelling. Okay, painful swelling is first clue in the anterior neck, and she has recent upper respiratory tract infection. Okay, she is having a viral infection. Okay, now laboratory test shows elevated ESR, which is supporting to be an infective etiology. A thyroid biopsy we have done, and they revealed the classical findings of subacute thyroiditis, which is granulomatous inflammation. The question is, what would be the thyroid hormone assay when performed after her URTI has subsided? Okay, this is very important. See, once the URTI has happened, this infection will go and stimulate your thyroid gland. This will cause destruction of those follicles for temporary time as long as the illness is lasting. So initially you will have T3 T4, same like your Hashimoto's thyroiditis, but once illness is resolved, okay, it will come back to euthyroid. Okay, so here they are asking when URTI has subsided. So if it is subsided, then the answer would be euthyroid. If the question has been, if the initial stages of URTI instead of after subsided, then the answer would have been hyperthyroid. Okay, this is very important. And remember, in subacute thyroiditis, you will not have hypothyroid state, because any illness usually won't cause will last, any upper respiratory tract infection will not last more than 7 days to 10 days. So that 7 days to 10 days is not enough for the entire thyroid gland to get damaged. So because of that, you will not have a significant hypothyroidism. Okay, you will not at all have hypothyroidism, you will just be in a euthyroid state or a initially hyperthyroid state. So these are, I hope these have consolidated your existing knowledge about thyroid disorders. So thank you all. We will meet in the next video.